Hello, everyone, and thank you for joining us today. My name is Paul Adepoju, and I'm the community manager for the International Center for Journalists, Pamela Howard Forum on Global Crisis Reporting. And like I always say during the since previous editions of these discussions, these initiatives started as our response to the COVID pandemic. And the goal has always been to help journalists in different parts of the world to improve their reporting skills. But with several other crises happening in real time in different parts of the world, and sometimes, as we are going to see today, crises overlapping, sometimes the country may be dealing with 2 or 3 or more crises at the same time. There is also the need to bring these issues to the attention of journalists in different parts of the world so that they know what the key issues are, what issues are being underreported, and what needs to still be done so that attention is given to some of these issues. And in 2022, the crisis in Ukraine, the Russian war in Ukraine, caught global attention. And while reporting has always been on the ammunitions, the numbers of deaths, the numbers of missiles, and the likelihood or non-likelihood of nuclear escalation, the impact of this crisis on several other issues may seem not to be getting the same attention as the war itself is having. But these issues are having life-threatening impact on different aspects of issues. And we also have people who are on treatment that may have their treatment protocol disrupted. But we also have stories of resilience, not just of artists or musicians that are taking guns and going to wars, but also of health workers that are still making effort to continue to provide services. And that's something that we want to highlight today on this conversation, to understand how the war in Ukraine is impacting HIV care. So allow me to welcome Sagi Antoniak, who is a researcher and infectious disease physician at the Institute of Epidemiology and Infectious Disease in Kiev, Ukraine. Thank you for joining us, Sagi. How are you doing today?
Hi, Paul. Yeah, thanks for inviting me. I would say I'm pretty much okay in the given conditions that we have at the moment. So how you been doing?
I'm doing well, so thank you very much. And we also have a second panelist, who is somebody I've known to be involved in this global fight against HIV/AIDS, I think for more than 10 years now, especially in Nigeria. You know him when he started going back and forth regarding enlightening people on how to actually from individual regional basis, and today is also actively involved on nationwide, on a well-positioned nationwide initiative, we would call it PIN. So let me welcome Onyekachi Onumara. Hi, Onyekachi, how are you doing today? And thank you for joining us.
I'm fine, Paul. Should I say happy World AIDS Day?
Oh, yes, it's Happy World AIDS Day. I think for people like you that are always involved in this AIDS campaign, December 1 is always a day that is important in your calendar. Sure. And if I'm not wrong, is there any other day within the year where attention is driven to HIV/AIDS issues more than December 1? Onumara, is there any other day in the year?
For us, 365 days, 24 hours every day, we are talking and discussing programming, reprogramming for HIV one way or the other. So December 1st is just the day we bring it to limelight for everybody to see that we're actually doing some things.
Okay, then I also want to ask Sagi, what is the World AIDS Day like this year in Kiev and in other parts of Ukraine, and how is it different from how it is usually celebrated before the war?
Well, to be honest, I fully agree with Onyekachi, because in my field, we are talking about HIV like 365 days a year, sometimes even 24/7 because of time differences that some of my colleagues currently have who had to move outside the country. And yeah, sure, today is quite different compared to previous years, but still we talk a lot. Today, many organizations that are involved in HIV care, they still work in the field. Our clinical doctors are still doing their best to provide HIV care to our patients. And yeah, so today is different, but the good thing is that we keep this feeling that today is one of the most important days for us, for those who are involved in HIV care. It's still as important as it was in the previous years. So yeah.
Yes, so I'll also like to welcome our participants that are joining us today. If you're watching this live stream on Facebook, we are usually on two Facebook pages. The pages for the International Journalist Network, IJNet. We say thank you for joining us. And if you're also watching us on our ICFJ Forums page, I also say thank you for joining us today. And if you are also on the Zoom platform, we are always happy to know where you are joining us from if you're with us. So you can engage with us and let us know where you are joining us from today. So if we look at the global AIDS scenario, the 1990 goal continues to be a rallying point for attention and for encouragement, for motivation, and for inspiration. So I know what 1990 is, but for those that are just hearing that unit go for the first time, Onyeka, I want you to break it down and the indications of how far we have gone, especially from your perspective in Nigeria, and what you think the issues are that are still limiting the achievement of this global goal.
All right, thank you, Paul. The 1990 goals, very ambitious goals set by the UNAIDS, that at 2020, 90% of those who are HIV positive will know their status. The second 90, those who are positive, 90% of those who are positive are placed on treatment and retained in care. And the third 90, that those who are placed in care, 90% of those who are placed in care will attain viral suppression. That is, at this point, the person can no longer transmit the virus, even through sexual route, which is usually the main route. It's quite a huge, just like the word says, it's an ambitious target. It's an ambitious target. But if we are aiming for the, if we are aiming for the star, if we hit the moon, it's not a bad one. But that's how ambitious the UNAIDS goals were. For us in Nigeria, I think last 2 years, we were able to see that we are 40% short of the first 90 while achieving the other two 90s. That is, the first 90 is looking at testing, prevention and testing, while the second 90 is looking at linkage to care, and the third 90 is looking at retention to care and achieving viral suppression. All these are different cascades of the HIV program globally and even in Nigeria. For us, what we have done, we, like I was sharing with Stella earlier, we have a very robust program. It did not grow out of the blues. We've made our mistakes over the years. We've learned, we've shared best practices, we've shared ideas. We've also had donor funds. A lot of donor funds have come into Nigeria in the past 20 years, especially global funds, PEPFAR, USAID, and the rest of them over the years. They've funded a whole lot of programs. And we keep inventing and reinventing approaches that work. Currently, we are doing what we call the DSD model, that is differentiated service delivery model, looking at who are those mostly affected by HIV, who are the drivers of HIV in Nigeria, and how can we reach this population with services that are unique, services that respect their human rights, services that will reach them unlike before. Because we found out that Nigerians, and especially male Nigerians, have very poor health-seeking behavior. We don't go to the hospital until it's almost late. My mother would say that we don't go to the hospital until we are close to the mortuary. So it means most Nigerians will try taking prophylaxis, taking some level of treatment, taking herbs, and even going spiritual at home. When all these things don't work, we start going to the hospital. And most of the time, the case must have become very terrible that they may not get the best of care that they would have gotten. So for prevention, we've done a whole lot of testing. A whole lot of testing. We took testing out from the facility more to the community, because since Nigerians will not go to the hospital to get themselves tested, a whole lot has been done in the areas of using community-based organizations to carry out testing at the communities. So we have also engaged key population organizations, because in Nigeria, as small as the key population is, they are the drivers of the pandemic currently in Nigeria. So a whole lot of attention has been shifted to that area, bringing key population-led organizations to run the HIV test in their, to identify community members, identify where they are, identify hotspots, get them tested, and if they are positive, linked to care. Another area we are doing very well is using behavioral change messaging, because we are trying to ensure that those who are negative remain negative, while we are also providing treatment for those who are positive. The inclusion of PrEP, that is pre-exposure prophylaxis, is also a good one that is also being invented and reinvented. I was told recently a project called Mosaic project that is being anchored by FHI 360. They are looking at using injectable PrEP. That is PrEP, okay, maybe for the sake of our audience, PrEP, there are drugs that they are antiviral drugs that are provided to persons who are negative, but who are at high risk of contracting HIV. They are placed on these drugs to ensure that they don't contract HIV. And research have shown that 80 to 90%, they are 80 to 90% effective if taken as prescribed. So for members of the key population who are at high risk of contracting HIV, PrEP has been also pushed forward in the course of our prevention activities. Then linkage is also an issue. Linkage, that is, I have been tested positive, now I need to go to the facility to take up ART services and other services. Remember, we are in a very conservative country like Nigeria, where a whole lot of key population activities are either criminalized or stigmatized or discriminated against and all that. So remember, these members of key population don't even want to go to the traditional health facilities in the first place. So now they are HIV positive, or they have come down with sexually transmitted infections, and they need to go to the health facilities. What we have also done in the course of our programming is to train healthcare providers to be sensitive to members of the key population. Members of the key population include men who have sex with men, female sex workers or sex workers in general, people who inject drugs, and the transgender community also. These communities, like I said earlier, are highly discriminated against, highly stigmatized, and in some cases even criminalized. So we've also looked at providing them safe space. We've come up with what we call one-stop shop. The one-stop shop is a center that provides healthcare services for only members of the key population. Since they are battling discrimination at the traditional health facilities, and that would be an impediment for them accessing healthcare service, we provided an OSS. The OSS are quite few because they are very, very costly to maintain. In the OSS, we have the integrated service delivery model, where we have both doctors, nurses, lab scientists, pharmacists, even therapists who give them some level of counseling. So this approach is also working. For that of, okay, I don't know, do you want to come in?
Yeah, I think.
Okay, so I don't say so much.
I think people like you can talk for what hours just talking about HIV. So
just stop me.
so Sagi, I want you to draw a sharp contrast on the situation in Ukraine. And one of the key things that I think is important, if I'm right, is the fact that the majority of your patients in Ukraine are actually women and not men, as the case is in Nigeria. And so let's know what is different, the HIV outlook in Ukraine, the progress so far, and how you still continue to provide services. And one question that is really, really important for me, if you can also weigh in, is is there a threat that is posed to 1990 goals in Ukraine with the current crisis?
Okay, thanks. Thanks for the question. And thank you so much for the insight regarding Nigeria, because I can say that we share some of the features, actually. Well, yeah, but the key difference is, I would say that out of 130,000 patients that we had on treatment before the war, 46.5% were women, actually, because in Ukraine, the main route of transmission is sexual, but it's heterosexual. And but yeah, we still share the key populations. So those are people who inject drugs, men having sex with men, sex workers, and transgender people. And but still, yeah, we've got a lot of cisgender heterosexual women infected in Ukraine, and also that brings us to the point where we have around, I would say, 2,500 women living with HIV giving birth to children every year. I'm pretty sure that this year the numbers will be less than that because of the war situation and because many patients with HIV were forced to move out of Ukraine because of the war. And so if just talking about the key features of our epidemic, our estimate number is 210,000. It was before the war. We also struggle mainly with the first 90 because before the war, we had 71.5% of those estimated of living with HIV aware of their HIV status. That was 150,000 roughly. And out of those, 87% received ART, and 95% of those receiving ART had viral suppression. So historically in Ukraine, we've focused a lot on social care and case management of patients aware of their HIV status and on treatment. I believe that's one thing that brings us to well, rather high numbers in terms of reaching the second and the third 90, because in almost all HIV clinics, there are social workers. Sometimes there are NGOs who provide social support and case management to every patient, and that includes reminding about the visits to the clinic, sometimes at the beginning reminding that about the features of the regimen that the person receives for HIV. And so those are the key features of our HIV cascade before the war. And of course, the war greatly affected the current situation. And the data that I currently have as on October 1st, we had up to 15,000 patients lost to follow-up of those who received treatment before the war started. This number sounds huge, and it actually is. It's more than 10% of the population of those on treatment, but there are still 115,000 of those who continue their treatment. And I must say that this multidisciplinary approach that we have, because the team includes a medical doctor, a nurse, a social worker, a case manager, that all helped a lot in tracking many patients because, well, huge numbers of patients were at risk of treatment interruption because some of the treatment sites were closed during the war. Some of them are closed now because people were not able to move to their treatment sites. And to overcome that, we've used this multidisciplinary teams to track those patients that were at risk of treatment interruption, who were at risk of missing their appointments to receive their medication. And that helped a lot because with the helps of these teams, we've tracked like more than 40,000 patients who are at risk of being lost to follow up and brought them, well, so I would say brought them back to HIV care. And the other thing that we've done is that currently HIV care is provided to every single patient in every single HIV clinic or ART site, irrespectively of where the person was registered before or where the person received medical care previously. So that helps very much to all the patients that are internally displaced people now, because whenever they need medical help in terms of HIV, they can just find the closest clinic and just get all the care they need right there at the place where their current stay. And for that, we have apps, we have a couple projects run by NGOs that provide this information to the patients. So basically, a patient can get information about the closest ART site 24/7 using at least 2 apps, one to Telegram bots, and websites, emails. I mean, there's a lot of this information giving component for the patients because, well, that is something that is the hardest for some patients, because when they're forced to move, they're forced out of their common life. So they need to look for housing, for food, for shelter, I mean, for everything. And for some patients, medical care is not the top priority, especially if they have children, if they have other family members that they care about. So we are trying to make it as easier for our patients to access medical care as it technically possible in these circumstances that we are facing. And the same goes for all the patients that are moving outside of Ukraine, because as of now, we know at least of around 4,200 patients that moved outside of the country. And we have huge involvement of professional associations, such as, for example, the EC network group, the Eurogan in Central and Eastern Europe, EACS, of course. And they're providing a lot of information for our patients. Where can they receive ARVs or get tested in given countries? And that helps a lot, because a lot of our patients who were forced to move outside the country, they have language barrier. And I know that many clinics, they even hired social workers that are Russian or Ukrainian speaking, and they have hired translators, interpreters, just to make the access to HIV care for our patients a lot easier. And well, yeah, also, yeah, please stop me, because I sometimes I can also go on like for way too long. Just feel free.
It's okay. I think I'm dealing with 2 individuals that are really passionate about the issues that they discuss, that they are working on. Now, Oyekachi, so what is the, of course, where you also practice is also prone to some crises. So what do you think the insights from responding to crises, and of course, the world still had to deal with COVID-19 when crises were everywhere, and still continues to deal with COVID-19. So what can we say as the pros and cons of dealing with multiple diseases at the same time? And what are your concerns about the global reporting regarding HIV. Is it impressive? What do you still think is still underreported? And I will also take that pose that question to Sagitu. Let's talk about your personal assessment of HIV reporting over the years. How has this been, and what do you still think is still not getting attention, even though the world has been reporting on HIV/AIDS for decades?
Okay, Paul, thank you for that question. Nigeria may not be at war with a superpower currently, but we've been having internal crisis for over 10 years now. It started with the Boko Haram terrorists in the Northeast. Later started having issues with farmer headers crisis in the North Central. Currently, we are battling with bandits in the Northeast, in the Northwest region of our country. So in the South also, we are having cases of uprising here and there. This crisis, no matter their magnitude, affect our programming. Sometimes when we do our weekly reporting, some states will not have reports to give us of some particular areas of their state because those places are crisis prone, or they came under attack, or farmer and headers clashes, or they had terrorist attacks, or they had cases of kidnapping. All these crises put together affects HIV programming, especially in states that have high prevalence rates. Let's take, for example, Benue and Taraba State. They are neighboring states. Both states have prevalence rates of over 2%, Okay, Taraba is about 1.9%. I think Benue is about 2% plus. So the national prevalence rate currently is about 1.4%. And these states, we are trying to ensure that we provide services in these places, then crisis hits. In those places, what we have done most of the time is to have areas, safe areas where we can provide these services for our clients. Sometimes also we have worked with stakeholders in those places who help us in drug refill, because sometimes our healthcare workers may be endangered. They cannot even go to those places. In Taraba, where I worked in some 2 years ago, some of my healthcare workers were caught in crossfire because they belong to one ethnic group that is fighting against the other ethnic group in the other place. So they can't even go to those places. So these things hamper services. We have increase in persons, what we call IIT, that is people dropping out of service. People who are supposed to come for their drugs are not coming for drug refills because of one thing or the other. So crisis is an issue, it's affecting us. Now, with the pandemic, it's now a double, what we call wahala in Nigeria. It's more like a double trouble of crisis, health crisis. We may not have had heavy heat like we saw in Italy and France and the US, but it's here with us. It's here with us. Now, to come to the question of reporting, I think we've not done enough. As much as NACA, that is the agency that is in charge of HIV/AIDS, HIV response in Nigeria, is telling us that we are close to achieving, seeing an end to HIV. There are still some communities that don't have access to HIV services. There are still some communities that have the access to HIV and health, any other health service itself has been cut off, either through some of these crises, sometimes even what do you call them? Cases of erosion. They've been cut off from mainland, and some no accessible roads to get to those places. These are things that are facing us currently in Nigeria. So I think we may have improved in our reporting, we improved in our surveillance, but we may not be reporting enough because there are still areas that we've not reached. Now, when I talk about key population, that's another kettle of fish altogether. We have a good number of members of the key population who have not been identified or who are unidentified. For example, most of the data we've looked at is showing that members of the MSM community that we are reaching are usually those between the ages of 16 and 35. So we have the elderly MSM community population are not being reached because these are population who will not ordinarily come out to access health services because of their social status in the community and because of the stigma and discrimination that comes with it. So I think we are doing what we are improving. We've made a lot of improvement. We made a lot of improvement in terms of reporting over the years, but there's still so much gap that we've not looked at. I just thought I should point that out.
Yeah, I'm even talking about journalists now. If stories, I'll come back to you, Oyeka, for a minute.
Yeah.
Osagi, I've read a lot about the impact of the war on HIV services. I've also seen a number of stories that highlights the local approach to ensuring that the services continue to be provided. But if you look at the reportage so far, are there any issues that you have concerned with in how it's been reported? And what do you still think journalists covering health issues as it affects the war are still missing out on the HIV response? Your mic is off.
Sorry, my bad. Yeah, that's a good question. And of course, there are always some fields that require extra attention, that require more attention than given, that requires some ways to overcome the new challenges. But I always try to focus at what we are doing currently to manage the most problematic areas, I would say. Because of course, one of the issues that we faced is, once again, is similar to what Onikachi mentioned in Nigeria. Some of our patients could not reach medical care because they were caught in the areas with active hostilities going on or active shelling, and it wasn't just safe to get outside of the shelter. So yeah, we've seen that a lot, but also in Ukraine we have just a review of what's going on. We have a rather decentralized healthcare system because we had more than 300, almost 400, I would say, ART sites before the war, and during the course of the war, only around 10% of them were shut down, and many of them continued their work even in the areas with active hostilities, and some of them continued to work in the occupied areas, which is another issue that we're facing, because in the occupied areas, it's incredibly hard to maintain connection with the clinics, with the doctors, and for them to maintain connection with the patients. And it is incredibly hard in terms of logistics, because even refilling the stocks of the clinics in those occupied areas is a huge challenge. And sometimes even humanitarian aid is refused by the local so-called governments, and that's one of the biggest problems that we're facing now in those occupied areas. Currently, they are refusing to accept even humanitarian help, to refuse ARVs for the patients, and they are just forcing the patients basically to interrupt their treatment, because also it's not safe to mention that they are HIV positive. And there is external stigma, there is self-stigmatization. So I would say that the occupied areas currently are the biggest problem and the biggest challenge that we are facing, because all those clinics that were damaged by the active hostilities, they are now either rebuilt or moved to other places. So we are pretty good in terms of those deoccupied areas, but those that are currently under occupation, that's a huge challenge. And I would say this is the main area that requires the most attention now, because we have a lot of people there, we have a lot of patients there, and that's something we need to talk about more than we do maybe. But...
Yeah, back to you, Yinka. So what are the, yeah, over to you. Yeah.
Okay, I wanted to add something which Sally just pointed out, logistics. In Nigeria, the alignment project, or the alignment project that NACA came up with, trying to merge implementing partners and donor agents, so that if, for example, Global Fund is working in Delta State, we should not have PEPFAR working in Delta State. If PEPFAR is working in Ondo State, we should not have Global Fund working there. So what they try to do is to put funds together. One of the things that most of these crises affect is distribution of commodities. When I mean commodities like condoms and lubricants that we use to distribute to both at the facility and at the community levels to members of the communities, especially key population. Accessing these things became very difficult even during the COVID, and also in crisis-prone areas. We have had a fall in distribution rates due to problems in supply chain. For reporting, I hope I understood that question part very well. One of the things that we've not reported very well are key populations. They're underreported. We're underreporting key populations in Nigeria. Of course, you know what the holders are, ensuring that even in a particular state where I worked recently, the state coordinator told me that there is nothing like MSM in their state. It doesn't exist. It doesn't exist. Later, when we started doing case finding and tracking cases and all that, and he started seeing things for himself, he was surprised. The recent survey that was concluded, the Integrated Biological Behavioral Surveillance Survey that we call IBBSS of 2020, puts the transgender community at about 28% prevalent HIV prevalence rate. Some people still tell us that there are no transgender in Nigeria, but they exist in Nigeria. So there's need to shine lights in these areas. There is need to understand the challenges of these communities, bring them to the limelight, and also need to channel more resources to those areas to ensure that at the end of the day, we are equalizing. Let me use the theme for this year here now. We are equalizing, because if in the next 8 years, which is the set date for the end of AIDS globally, we are still far behind. We are still behind. Let me not say far behind. We are still behind when it comes to key population. We've achieved quite a lot on mother-to-child transmission of HIV. We've done beautifully well, and we can still do better. But when it comes to key population, we have not done enough. We have not done enough. Most of the reporting, females who inject drugs are underreported. We've not seen a lot of light shine in that area. Another population that we have not gotten so much funding for and resources channeled to is people who are in prison. They are also key population. They are also key population by UNAIDS definition. They are also key population. We've not done enough in that regards. And World AIDS Day like this and programs and platforms like this are a platform that provides us to shine the light towards those directions, that there is need for us to look at this area. There's need for us to do more reporting in this area. Journalists should beam their searchlight in these areas too. Donor agencies should beam their funds in this direction. The next thing that Nigeria will be doing now is what they call alignment 2.0. 2.0 means that implementing partners are handing over to government because of the dwindling funds, and so that government can handle these things in the next couple of years. There's a whole lot of challenge that's going to come out of that, because we know how things done. One of the successes, one of the reasons for the successes we achieved in Nigeria is that most of our intervention have been private-led by implementing partners, by NGOs and all that, but the government providing support and oversight. So I hope we can still sustain the gains that we have made using these platforms over the years and sustain them, especially things like the OSS I talked about. It costs a whole lot of money to run a one-stop shop where key populations are taking up services. How will the government fund them? Government that we're having issues funding primary healthcare centers will now start funding the OSS against a community that they criminalize and stigmatize and discriminate against. We just hope for the best.
Yeah, I think that was another really impressively passionate comment. So Sagi, let's talk about now. I'm the advocate for journalists. I'm speaking for journalists. I've also been able to report one or two issues on HIV, and most of the time, it looks as if it's still difficult, especially in some parts of the world, for individuals that are living with HIV to come out openly, tell their stories publicly, and have their faces splashed on the covers of to actually humanize those kinds of stories. We know, if you know, HIV advocates, HIV, faces of HIV, individuals who have come to terms with the HIV status and are also willing to ensure that people learn from their stories. That without those kinds of voices, it may be extremely, really difficult for journalists to be able to write really good stories that put attention, that humanizes these issues that you're talking about, especially the gaps. So my question is, probably it still ties to with the stigmatization, the stigma that's associated with the disease. And so the question is this: over 40 years of dealing with HIV, why is stigma still a big deal? Why are we still? And what is the situation in Ukraine? And how do you think, what is your advice for journalists that really need to do this in spite of the challenges that they're expected to face? So I'll start with you, Sagi, and I'll also come back to you, Onyeka.
Okay, so what's the situation in Ukraine? Yeah, of course, stigma exists. I mean, unfortunately, I don't know a single country where there is completely no stigma in terms of HIV, and it's a global problem. And I would divide it in two different parts. One of it is the external stigma, the stigma of the society, and the second one is the self-stigmatization. Because what I see in my patients, self-stigma in many cases is even a bigger problem, because people stigmatize themselves, and they are living in fear that if they come out with their diagnosis, they will be rejected by their family, they will lose their job, they will lose their friends, and many other issues. But in many cases, in most of the cases, when people come out, I'm talking about my patients from my clinic, and experience of many of my colleagues, nothing changes in their life, basically, because their families accept them, their friends accept them, they are not losing their jobs. So I would say in Ukraine, self-stigma is well, is a huge issue. And I always tell my patients that
and many other issues, but in many cases.
Oh, sorry, I just heard myself for a moment. Oh wow, my voice is not that good.
Your voice is great. You're sounding nice.
It's fine. It's fine.
Sorry for that. It's always unusual to hear yourself in your recording. So, yeah. So I was talking about self-stigma, and what I always tell my patients that in 2022 now, HIV is not the disease it was like 20, 30 years ago. It's an absolutely controlled condition, basically. All you need is you need to receive your treatment on a daily basis, and you've heard, well, let's not talk about injectables current, but well, you just receive your stable treatment, you control your viral load, and that's it. Because the life expectancy is pretty much the same as in the non-infected general population. The health profile is pretty much the same to the general population. So, and of course, U equals U. So, I mean, these people have no threat in terms of potential infecting other people. So basically, it's an absolutely controlled condition now. And of course, we're all looking forward to the cure, but I mean, no one is stigmatized because they have diabetes. But it's pretty much the same, because for diabetes, you also need to receive a treatment on a daily basis. And it's a very serious condition. When untreated, it can cause death. But it brings no stigma to those with diabetes. I mean, it's just a condition that can be controlled and must be controlled. And that's what I tell my patients mainly. That's pretty much the same. You just need to find your treatment, which is good for you in terms of adverse events, in terms of tolerability, and that's it. And you live a happy life. You can have children. You can get married. And it's what the biggest problem is that society doesn't know that. I see the huge role of journalists is promoting this approach that it's not a life sentence as it was some years ago, because I've seen the headlines like 20 years ago that it's a death sentence and that's it. If you have HIV equals it. No, it's absolutely different. It's not like that anymore. And that's what our society should be taught. That's what people need to understand, because that goes what Anikachi said in terms of MSM population. The younger population now, they just Google it, and they pretty much know that it's safe to talk to people with HIV, to have different relations with people with HIV. It's okay. But the older population, they are harder to reach. And the level of self-stigmatization is way higher in the older population. And that's also, I believe, something that could be changed by journalists just bringing this attention that it's nothing more than a controlled condition, and that's it. Yes, it's dangerous it's important. I would say it's not dangerous. It's important to treat it. It should be treated. But that's it. I mean, just take your medicine and then live a happy life.
I think it's not that simple. Onyeka. You have a flag.
For us in Nigeria, we come from a very conservative society. Society is very conservative. Somebody said something. He said, sex is a cult that everybody belongs to, yet nobody wants to be called a cultist. The stigma attached to HIV, it's also because it's a sexually transmitted infection. It's a sexually transmitted infection. And once you are positive, you are termed a promiscuous person. That's the point. Most people don't want to ignore or don't know that you can also contract HIV through other routes. Stigma, I also want to agree with Sergey that self-stigma is also part of it. But in Nigeria, society stigma is higher, is still higher. We have done some things actually over the years. We've tried behavior change, communication messaging, the agency that takes care of AIDS in Nigeria have done quite a lot in messaging, but we've not done enough. We've not done enough. Some of the things we've done include changing the meaning or how HIV is interpreted in our local languages. For example, in my Igbo language, before now, they call HIV Ubirinajocha. What it means is that you have got an infection that will end in death. That's tragic. You have got an infection that will end in death. That's just what it literally interprets. They've started changing those languages, even for the other local dialects. They've started changing those words so that people can see HIV/AIDS from the angle Sergey is coming. It's just an infection. It's just a disease that can be better managed with the drugs that are available now. We have better treatment options than we've ever had in the history of HIV and AIDS. We have better informed healthcare professionals, better trained healthcare professionals now than we've ever had in the last 20 years. Before now, even healthcare workers were running away from HIV patients and all that. But things are changing. People are seeing from that light. So there's still so much that we need to do in messaging, using the religious organizations, because our conservatism stems from both religion and culture and tradition. So we need to use our traditional, our religious leaders to pass the message, that this is what this is. If you have HIV, it's not a death sentence. It's not judgment from God. It's not a condemnation and all that. When people start seeing this from different angles, and also having what we call HIV champions, people who can boldly come out and say, I am HIV positive. I have been on drugs for 6 months, 1 year, 2 years, and look at me, I'm living a normal life. I am married, I have a child. These people should come out and become champions. Imagine if we have, I'm not saying, I don't want to call names, I don't want to call names. If we have some big stars, big celebrities in Nigeria who are HIV positive, boldly come out and say, I'm HIV positive, and I'm still able to achieve everything. I'm still able to pursue my career and achieve everything I wanted in life, and I have made it. These drugs help me. Until we start putting a face to this, we still have quite a long way to go. Stigma is still an issue. It's still an issue. Discrimination is still an issue. It's still an issue. Unlike where Sergey is coming from, where you might not be stigmatized if you have HIV in your workplace and all that. It might not be the same in some places today. Come boldly and say you have HIV, you definitely have to have your colleagues to contend with.
Okay. Thank you very much. Wow, we only have a few minutes to go. So let me start with this. So what are your expectations? What are you optimistic about regarding the AIDS response? And what is your advice for journalists that are covering this subject? Let me start with Sergey.
Thanks. Thanks for the question. My expectations, well, I'm definitely looking forward to new research in terms of HIV treatment, because I fully agree with Nikachi. We are currently at the best place in terms of HIV care than we have ever been. And it gets better and better every year. So, of course, I'm looking forward to HIV cure, to long-acting drugs and their implementation all over the world, because unfortunately they're not yet available in Ukraine. And I'm pretty sure that as long as we do our job good, I mean, all those involved in HIV care on all the levels, we will be able to do everything. We can change our policies in the countries. We can change the society attitude to this disease, and we can do that. And I truly believe that the role of journalists currently is bringing society to a point where HIV will be recognized as a simple medical condition. Just this, I would say, well, for me and for the colleagues from the journalists that I know, from the NGO sector that I work with, that's my main message usually for them. Just bring the society to a point where everybody will understand this, and then we'll have the stigma will disappear by itself. So we should not, I would say that our main goal is not finding stigma as it is, but bringing the society to a level where there will be no stigma. And this is the easiest way as I see it. Thank you.
Thank you very much.
Okay. I'm optimistic. With all what we've done in the last few years. We are heading somewhere. Like I said, Nigerian HIV response has been robust with all the lessons we've learned over the years and with the fundings that have come in now. I'm optimistic that government would take over the HIV, both prevention and treatment angle and treatment itself, which they have been doing. They can improve upon that. I see them doing better because of the kind of leadership they have currently. If we continue with that trend, but it should be slow and steady. There is no need of rushing it. There's no need of rushing it, and they will do well because the donor funds are gradually reducing by the year, and they will not be there forever. So it's time we look at sustainability plans, solid sustainability plans that will ensure that those who are on treatment remain on treatment, and that will continue with testing. Yeah, testing is more targeted now, targeted testing. You're no longer testing everybody like we are doing. We are ensuring that we use approaches that narrows down those who actually need to be tested. And by that means, we are getting more positive. For journalists, I think there is need, I want to buy into what Sergey said. Journalists should keep letting the public know, letting people know that this is where we are. I posted on my Facebook this morning that an HIV positive mother can have an HIV negative baby, that it's possible. Some people are surprised. Wow, is it possible? These are areas that we need to shine light, that it's happening, that being HIV positive does not stop you from living a normal life. It doesn't stop you. These are areas we need to shine the light. We have a thriving movie industry. We need to shine the light, make movies that humanize HIV, for all people to see that it's humans that go through this, and show positive angles about things that we have done, things that we've achieved, and maybe also the challenges and how we can sort them out. I really want to say that in the next few years, I hope and believe that an end to AIDS is possible. It's very possible. We may not achieve it by 2030, but I don't see it exceeding the next 15 years, 10 to 15 years. That's me. Thank you very much.
Yeah, so thank you very much. On behalf of the International Center for Journalists, I want to thank the two of you for joining us today. And we appreciate your insightful contributions, your knowledge, and of course, your expertise in this field. And for journalists attending, watching live on the various channels. I say thank you very much. Sorry we couldn't take your questions. I did know we've already exhausted all the time. And so if you have any question that you would like me to, any of these awesome guests to address, do not hesitate to reach out, and we are going to pass these questions on to them, and they're more than willing to answer these questions. And for more information, and one of the ways that you can, for those that have already been sending messages regarding requesting for videos of this session, just be aware that the videos of this session would be available very, very soon, usually within 8 hours, would be available on ICFJ's YouTube page. Do not hesitate to check it out. And but for you to be able to quickly access it, you can join our Facebook group, where we share tools, resources, and insights that may be of benefit to you. So just click the link that I just put in the chat box, and we are going to ensure that's what we are going to share the link of videos when they become available, and other resources that we may consider to be useful for you. We have a very thriving ecosystem of journalists in different parts of the world, and we network, and we share resources in person and online, and we hope we'll continue to do that. To learn more about the International Center for Journalists, please check out www.icfj.org. We are also encouraging you to access resources on MyJNet on www.ijnet.org, and these resources are in different languages, up to 8 languages, and they cover a whole lot of topical issues that you may consider relevant for you. So on behalf of the entire team behind this production, I say thank you very much for being with us today, and enjoy the rest of your day, and we'll join you and we'll see you next week. Bye from me.